Hello, everyone. My name is Sourabh, and I work as a manager in global markets team at Clinton Health Access Initiative, where we predominantly work on supporting global vaccines and pharmaceutical manufacturers to ensure sustainable access of life-saving health commodities for low and middle-income countries. In my talk today, I will focus on vaccine market dynamics in public health markets. The three broad contours of my talk are a brief introduction of CHAI, role of vaccines, and how can we help in improving or closing the immunization gap using a market shaping approach. So this slide basically gives you a snapshot of CHAI's vast spread and network. CHAI's mission is to save lives by increasing access to quality assured commodities and services in developing countries. CHAI is headquartered in Boston and has over 1,300 staff in over 32 countries across the world. What you can actually see is that we've color-coded the countries slightly differently. The countries which are dark blue is where we have a CHAI country office present, with at least one or more representative based out of those countries, whereas the ones which are slightly lighter shade of blue are procurement consortium countries, which are able to CHAI was set up by President Clinton in 2002. We started off with HIV-ARV as a flagship program. Since then, we've expanded to malaria, TB, vaccines, nutrition, health financing, zinc ORS, and recently cancer. Slide 4 gives you the foundation of our work, where the market interventions and simultaneously engage with both supply and demand side stakeholders. So CHAI operates on both the supply side of the equation through having supplier-facing interactions. The graph on the left shows you an example of the stakeholders to reduce the price of tenofovir disoproxil, an HIV-ARV drug, whereby in 2006 the price was cumulatively around $207 per patient per year. CHAI used a multi-pronged strategy where we worked on engaging and encouraging new suppliers to enter. We worked on optimizing the process. We had actually process chemists who looked at developing a more economical and more viable manufacturing process. And we looked at aggregating demand. All those various factors played a huge role in bringing the price down from $207 per patient per year to $78 per patient per year. On the demand side, we collaborated with various stakeholders and government to include new products and treatments in the national and international guidelines. We help in product adoption and uptake. We also support the country governments in forecasting and understanding the demand for certain products within their provinces. The CHAI's vaccine strategies focus at 4 key areas. The first one being accelerating new vaccine introduction, where the goal is to increase the speed with which new vaccines are introduced and reach target coverage. The impact here is inclusion of new vaccines will significantly reduce the mortality and morbidity associated with vaccine-preventable diseases. We also help and support government strategy and capacity to introduce future new vaccines. The second tower is improving vaccine delivery, effectiveness, and efficiency, whereby we focus on improving the efficiency and effectiveness of vaccine cold chain and logistics. This overall has an impact where we are able to increase the immunization coverage and timelines of routine and campaign immunization with safe and potent vaccines. The third pillar is improving immunization strategy, planning, and implementation, whereby our goal is to enhance planning, resourcing, and implementation of national immunization strategy, and the impact and how we desire for or strive towards is a significant improvement to immunization management systems achieved and sustained, and increase in sustained routine coverage. The child vaccine delivery predominantly pillars. The fourth pillar is affordable and where we work helping countries sustainable immunization programs vaccine prevent disease. In cold chain, because recently embarking on a large scale vaccine antigen procurement and rollout of so we not only do we support countries in procurement but also understanding what type of cold chain equipment would be most suited for those conditions. I will now shift gears and talk about the role of vaccines. Immunization is the most cost-effective public health intervention with a tremendous global intervention with some equating this to something similar as the best part of global public health. Vaccines save tremendous lives. Approximately 2 to 3 million deaths have been averted every year since the rollout of national immunization programs in 1974. Pneumonia and diarrhea vaccines in developing countries that additionally save. They're very cost effective. There is substantial empirical evidence that vaccines contribute to economic and social development through direct medical savings and net indirect economic benefits. Estimated return by a recent study done by researchers from Harvard and Darby equate the estimated return on investment for immunization as high as 18%. And this has recently resulted in creation of international finance facility for immunization bonds, which has so far raised about $6 billion to spend on immunization. Vaccines also have an enormous global reach of about 136 million birth cohort globally. Around 80-82% of them access vaccines. So clearly they reach around 120 million kids worldwide. JAI has a presence in 8 focus countries where we support the Ministry of Health in some form or other in 7 African countries and in India. The 7 African countries are Cameroon, Ethiopia, Kenya, Lesotho, Nigeria, Tanzania, and Uganda. Vaccines have a significant impact, as the slide suggests, in averting under 5 deaths. On the left-hand side, you can see a chart which maps out the various drivers of under 5 mortality. Pneumonia and diarrhea is 30% of those deaths which could be prevented. And now we have a vaccine which could easily be the number of deaths in countries of Nigeria, Ethiopia, and Tanzania, Malawi, rolling out vaccines which prevented the diarrheal or also known as pneumococcal conjugate vaccine, which is part of the pentavalent vaccine. Now, in terms of while we've actively talked about how vaccines are important, and we established that, we will now move on to how we can close the market or improve the market shaping and close the immunization gap. Vaccine volumes and costs associated with vaccine procurement have increased dramatically with introduction of new vaccines, and hence which requires a transformation of vaccine delivery systems and management systems. So, for example, this slide captures the data for vaccine procurement on the top half of the graph for Ethiopia, and the bottom half lists down the cold chain requirement for a country such as Ethiopia. About 10 to 15 years back, there was a huge disparity or a time lag from a new vaccine which used to get introduced in a developed country to the time it would take for it to be introduced in a developing country. That gulf has reduced significantly due to the role of various stakeholders such as country government, Gavi, and the Gates Foundation. Now we see any vaccine which is rolled out in a developed country in a few years, sometimes less than a year, also being available or accessible to developing countries. So this obviously, while it creates addresses one need where kids are getting vaccines, but also creates another opportunity where countries need to now invest significantly in improving their vaccine management systems. So, for example, this graph highlights that Ethiopia now procures or uses vaccines worth $80 million every year and requires about 500 million centimeter cube of cold chain space to support and implement its immunization systems. This slide gives a snapshot or a summary view of the Indian immunization program. Now, India has the world's largest national immunization program, which caters to about 26 million infants and 30 million expectant mothers every year. The EPI program is managed through multiple cold chain points across the length and breadth of our vast country. Indian birth cohort is approximately 31% of the Gavi eligible birth cohort, and hence any decision by India to include a vaccine will have a significant impact on the global demand and supply dynamics for all key vaccines. India has recently rolled out IPV rotavirus and measles rubella vaccine and has plans to roll out pneumococcal conjugate vaccine, NHPV, going forward as well. Adoption of new vaccines has resulted in increased value of vaccines being procured by public health agencies. The graph on the left side suggests the vaccine procurement by UNICEF supply division, whereby it has actually grown 18% compounded from 2010 to 2015. So in 2015, UNICEF SD procured vaccines worth $1.7 billion as compared to $750 million in 2010. Now, this has actually been correlated by the augmentation of new vaccines in the traditional vaccines. So on the graph on the right side, you can see how PCV and new vaccines such as Rota and IPV are now sort of augmenting the vaccine procurement budgets for various low and middle income countries. As you can see, PCV and Rota and Penta are now the top spenders for UNICEF in 2015. What we do need to appreciate as well is that while vaccines are being procured in large quantities, but however, the way to manufacture and procure and develop vaccines is slightly different from how small molecules or traditional drugs or chemical entities are manufactured. Because vaccines have an inherently long gestational period for it to develop and manufacture. And increased demand for existing and new vaccine mandates the suppliers are aligned with requirements from key stakeholders. So in the next few slides, we'll talk about how vaccine manufacturing is slightly complex, slightly different from the small molecules. In this slide, we like to show that vaccines are unique products with a complex manufacturing process and require a very customized approach. Vaccines are highly product sensitive. They are actually biological products where quality is a key criteria. Considering that they are biologic products, there is inherent risk of production failures. There is a stringent national regulatory authority. So unlike the small molecules which could be approved by the state FDAs, in this scenario, you do need the central TCGI and the CDSO to give you an approval for your product. Majority of the vaccines do also require cold chain, whereas now recently we've seen some vaccines being developed which can stay for a long time in ambient or room temperature conditions. And they also have a limited shelf life, which is predominantly around 24 to 36 months. Vaccine manufacturing is more complex. It requires high upfront investments on R&D, clinical trials, and plant construction. Whereas we recently heard about how a new vaccine plant or a greenfield manufacturing site would require about 3 to 5 years of time for it to be set up. Hence, the suppliers need to plan much ahead as compared to other products to be able to supply vaccines going forward. The other complex scenario is that even though the vaccines could be similar to other existing vaccines, but there are no generic vaccines, you still have to undergo stringent clinical trials for all new vaccines being developed. There is also a timeline for increase in production capacity, which is about 2 to 3 years and requires regulatory approvals. There's also initial process selection in terms of what product and how do you manufacture your process can have a long-term impact, because obviously how you produce, what yield you can generate from your cell line and in manufacturing process will actually go a long way in determining what sort of economies of scale you'll be able to develop. So hence, I think net this slide probably is a good way to illustrate that vaccines are slightly more complex than small molecules. Hence, there's longer time for it or longer lead time required for them to be manufactured and produced and developed. So hence, the suppliers need to be aware about 5 to 6 years before a new vaccine is included in a country's immunization program, so they can go ahead and manufacture accordingly. This slide captures the various product and market barriers which can negatively influence management's decision to invest in vaccines. This lists that suppliers face numerous barriers in the life cycle of product development. In early vaccine development, there are obviously high development costs. There are clinical trial risks associated with, in terms of would the product be good enough as compared to the comparator or the other placebo conditions. And there are also no suitable vaccine benchmarks to measure the correlate or immunogenicity or efficacy for the vaccine. For example, a good example was the Ebola outbreak in 2014, whereas there was a couple of vaccine manufacturers who were very close to developing a product, but the Ebola incidents were actually now trickling down, and hence there was no way to measure the efficacy of the vaccine unless doing it in vitro or computer modeling. The other challenges is the market introduction, where while suppliers would love to have a crystal ball to be able to gaze and predict what the demand would be for their products going forward, but it's a very fluid and dynamic environment where there could be one vaccine one day and the vaccine demand may shift or be cannibalized to a different product which has a higher valency. There is also unclear vaccine delivery in terms of some countries or some stakeholders may decide that they would rather have a combination or a standalone vaccines because obviously combination vaccines would result in less immunization or less needles being injected into young infants. Price sensitivity plays a key role in public health vaccine introduction because obviously the country governments and key stakeholders are managing various different health programs and there's only a set pot of money. So they need to manage the funds accordingly and assess the need for a new vaccine vis-a-vis supporting other health programs. Also, the other challenge which suppliers also face is some suppliers are not geared towards getting WHO pre-codified. And increasingly, we are seeing that a lot of country governments and key stakeholders around the world insist on suppliers getting a WHO pre-Q. So apart from an approval from their national regulatory authority, they're also requested or asked to get a WHO certification, which is certified by WHO and enables the suppliers to supply their products and vaccines to key countries. The final challenge is scaling up. Now, vaccines are generally high volume and low value products as compared to other biologics. So in terms of for countries to be able to access vaccines at a lower price, a certain manufacturing scale needs to be achieved to be able to hit economies of scale. And for the manufacturers to be confidently able to scale up and invest significant amount of money to be able to ramp up capacities, they need certainty of demand. Any guidance, any insights in terms of how the future market would shape up gives the supplier a lot more confidence and be able to offer the product at a lower price because they can reduce their risk premium associated with not being able to sell the product. There's also funding uncertainty. As countries graduate from support from global stakeholders, Gavi and Global Fund, there is always would countries be able to sustain their own immunization and other health programs when global stakeholders are no longer supporting them. There's also regulatory risks while scaling up. If the demand shifts, for example, we recently saw that the SAGE recommendation, which is Strategic Advisory Group on Immunization, suggested that moving from a 3-dose of HPV or cervical cancer vaccine to a 2-dose. So suddenly, if there was a demand for about 100 million doses for a certain vaccine, the demand moved down to 66 million doses. So all these are myriad challenges or risks the supplier faces when they are deciding which products to prioritize and going forward. Hence, the management has limited ability to prioritize and make necessary investment decisions. The management have multiple criteria or concentration when they are evaluating products and pipeline portfolio. One of them is allocation of limited resources based on expected returns or NPVs, which is or internal rate of returns employed by various finance heads within the firms. Budgeting for investments required in manufacturing capacities and capabilities, prioritizing markets and creating market entry strategies, and aligning with overall or broader company strategies. For example, there are certain suppliers who would like to focus on enteric disease. That's how their portfolio is geared towards, whereas some are more geared towards meningococcal or pneumococcal disease. So you also see suppliers, looking at portfolio products and then selecting if they align with the overall broader portfolio before this venture into developing their products. The final slide lists down the various key pillars which we believe a manufacturer needs to invest in to be successful in public health markets. A supplier needs to have a robust commercial and product portfolio strategy. They need to have international standard physical manufacturing assets. They need to have system-wide international quality standard and enforcement processes. They need to rigorously and regularly invest in PQ processes and resources. Clinical trial design and implementation, where they have multi-center clinical trials, which accounts for various gene pool and various population sizes, and also account for different immunization schedule. For example, we recently witnessed that some certain countries have gone for a 3+0 schedule for PCV, whereas some countries are leaning more towards a 2+1 schedule for PCV. So trying out these different immunization schedules, dosing regimes would also be helpful, and across different trial centers to generate large amount of data. The sixth pillar we believe, which plays a key role for a success of a vaccine manufacturer, is having the more efficient or low cost base. So being able to develop or produce a vaccine at a lower price gives them a huge advantage as compared to other peers, and also puts them in a more advantage situation as compared to other suppliers when they do bid for competitive tenders. And one way we've noticed a lot of suppliers do that is when they are able to allocate large production capacities by splitting their production capacities between public and private health markets. The seventh pillar which we identified with our stakeholders and key experts was setting up collaborative and international partnerships with key stakeholders globally. And finally is the organization structure and culture. So having quality management systems, having robust manufacturing systems, having compliant and adhering to those compliance systems has to be the company-wide culture to avoid any nasty surprises going forward. So net, having the right products or right product portfolio for low and middle-income country markets, having international manufacturing and quality standards, having an efficient cost structure, which is basically splitting your production capacities for high and low income countries or public and private markets would give you larger capacities, so you're able to allocate less of the fixed costs in the public health markets, which you can then be competitive and be ready for achieving W2PQ. Would all these factors significantly help any vaccine manufacturers to be successful in public health markets. So with this, we come to an end of the presentation. I will be now open to taking any questions you may have, and thank you for being such patient listeners.
So our first question is from Vibhu. What's your selection criteria for introduction of a new vaccine?
Right. So I think the introduction, if I'm from a supplier's perspective, if they were to include a new vaccine in their portfolio, they would need to look at the market. Is there a need for this vaccine? And is that a set need, or is this more of a opportunistic, such as Zika or Ebola, which sort of an epidemic disease which may emerge, which could be a different subset of the market. Secondly, would be the former choice which I said, it is already a vaccine which is required for a certain indication, a certain disease. And does the supplier have the right capacity or capabilities within the house to go and develop that product? It may require intensive conjugation. It may be a bacterial or a viral vaccine, and the supplier may be actually geared towards a cell culture vaccine. So looking at their manufacturing expertise, looking at is it a market fit, and would they be able to make it, and also looking at the complexity. So those 3 or 4 key factors would play a huge role in suppliers selecting a product. In terms of countries, when they select, they look at the disease burden in their respective countries, or what is the incidence and the mortality and the morbidity associated with those vaccines. Are there any adverse events? And obviously, when they also look at how does this impact any other choice investment decision they may have for other vaccines. So how does that compare against some other vaccine which they're evaluating? So what are the dailies or the number of cases averted, and what is the dollar value spent in reducing that number of mortality or morbidity? Hopefully I answer that question. Thank you.
The second question is from Ishan. PCV in public market in India. Please give your views on this.
I guess, Indian government has already decided for PCV in India. It's a matter of when rather than if now, in terms of when the vaccine is rolled out. It has been a very successful vaccine across the world and has been a key driver of reducing mortality and morbidity associated with pneumococcal disease. So I guess, while I'm not a disease expert, I believe it's actually a very, very right choice and to roll out the PCV vaccine. I think UP, along with other couple of other states, have been selected for a phased rollout starting this year. Yeah, so definitely it's a very great or a historic decision by the government to roll out the vaccine.
Next question is from Geeta. What are the Clinton Health Access Initiative, and what are the benefits?
I guess, in Indian government has already decided for PCV in
efforts to address the issue of child diarrhea in India?
Thanks, Geeta. So what we focus, we actually worked on something called a zinc ORS project, whereby what happens is when child suffers from diarrhea, they're not able to absorb any food, right? Their gut actually just releases everything which goes in. So zinc and ORS is actually key ingredient which is needed for the body to start absorbing key nutrients. So CHAI successfully ran a 3-year program in the state of MP, certain districts of Uttar Pradesh and certain districts of Gujarat, where we worked with private and public health practitioners to incorporate zinc ORS treatment guidelines, where rather than giving 1 or 2 sachets of zinc ORS, it was going to be a 7-day or 14-day treatment for severe diarrhea-related deaths. So I think diarrhea, there is of the diarrhea disease burden, say for example, if there's 500,000 deaths due to diarrhea, about 100,000 of deaths are due to a rotavirus infection, which could be prevented due to a vaccine, whereas the other are due to lack of zinc ORS and other infections. So you need to work or address diarrhea with a different or multi-level strategy, and zinc ORS was one layer, and rota is the other one which the government's already working on. We've already rolled out, or Indian government has already rolled out Rotavac vaccine in 4 or 5 states so far, and they plan to ramp up the rollout because that's been very successful so far. So again, congratulations to the government for doing such a great job so far.
The next question is from Sonal. How improvisations in delivery system can improve the immunization scenario of India?
I guess improvement is an ever ongoing process, it's a constant evolution of how things happen. There are already talks of having moving from a single to a combination of vaccine. For example, we used to have DPT and separate Hep and separate Hib. Now we have a pentavalent, so that reduces the number of pricks child would be getting, and also in terms of number of vaccines which have to be stored in a primary health center or an outreach center. So that's obviously improvement in the vaccine delivery system. The other is the government's recent Indradhanush campaign, which goes about for MR, JE and other key vaccines. I think for MR, we have very ambitious plans rolled out by the government, which we are going to target about 400 million kids to get a dose of MR from anyone ranging from 0 to 15. So there are different levels or different interventions which are taking place in terms of vaccine delivery. Another one which I could think of is for IPV. So IPV, there was a global shortage of the SAW IPV, and the government has, and India being one of the lead partners, is now using intradermal route, because for intradermal you only need 40% of the vaccine you would need for intramuscular, and hence because there was a shortage, so there was an option of either not give the vaccine to a population or go for the intradermal route and then deliver the vaccine. So India has taken that call, and the results have been very promising and positive so far, and the learnings from those clinical trials or those actual delivery is now being taken up and taken as a test case in other countries for a successful intradermal rollout of IPV vaccine.
Next question is from Cheshta. Can you share some insight on the integrated vaccine complexes to be established as suggested by National Health Policy 2017 in India? How will it impact the future of vaccine industry in India? Where do you see the future to be?
I believe the integral vaccine manufacturing complex is being established or has been established in Chennai or near Chennai. I do not know in terms of what the status is in terms of how many vaccines are being currently manufactured or produced, but it's clearly a decision made by the government about 7 to 8 years back, and the intent there was to the IVC or the integrated vaccine manufacturing complex to provide a large chunk of the vaccines required for the Indian domestic immunization program. I guess the impact of the IBC coming online and how that would play out for the domestic vaccine manufacturers is yet to be seen. Um, the jury's still out there in terms of how that happens.
Next question from Shivani. What are the economic benefits from vaccination for the government as well as the families?
Sure. So the economic benefits for anyone who gets immunized is obviously very minimal number of morbidity or mortality associated with that vaccine. For example, if a child does get rotavirus vaccine, is less likelihood to get a rotavirus associated diarrhea. So obviously the kid doesn't need to go to the primary health center or to a doctor to get treatment, but invariably whenever the kid needs to go, the mother or the father also need to accompany them to the primary health center or to a doctor, and they would not be doing anything economically productive rather than taking care of the recovering child. So those were the broad parameters of the study done to evaluate how immunization has a positive impact on economic activity in countries. And it serves as a more of a prevention tool rather than a curative tool because it's so early in a child's life. So hence, most of the vaccines we see are prophylactic in nature rather than therapeutic in nature.
Next question is from Sanjay. Apart from manufacturing, what are the criterion for the distribution and supply chain of vaccinations in India for private players?
So I'll try and answer that question for the public health markets. So how the Indian vaccine markets is currently split is that the Indian birth cohort is around 25-26 million. About 85 to 90% of those kids access vaccines through the public health system, and 10 to 15% of the 25 million access to the private healthcare through local sets of pediatricians or GPs or doctors who immunize the kids. So for public health system, the government procures the vaccine. They do a competitive tendering process. They sometimes do multi-year tendering, i.e. 2 to 3 years. Sometimes there will be annual tendering where they would put out an RFP and suppliers would go and bid for it. Once whoever is the winning bidder of a certain vaccine would be selected, and then they would be awarded the contracts or the delivery schedule will be shared with manufacturer. Post that, it's the manufacturer's duty to ship out the vaccine as per the agreed terms. Depending on the vaccine we're referring to, they could be going to national store centers, which are 4 across the north, west, south parts of the country, or to the state capital stores. Once the manufacturer delivers those vaccines at those respective stores, it's actually down to the government and the government's immunization programs division to manage how the supply chain moves going forward from those centers right down to the primary healthcare centers. In terms of private sector, it's a very different or complex play in terms of those private manufacturers have their CNF or carrying forward agents in various states, and they supply or ship out their vaccines to the CNF. They also have their local sales and marketing team who would reach out to pediatricians, GPs, and doctors to educate and make them aware about their various products. Hopefully I answered that question. Thank you.
Next question from Shivani. Vaccine wastage is a big issue. How do we make vaccines available in poor countries and far off areas where cold chain suppliers are not available?
I think, yeah, you're right. I think vaccine wastage is definitely a large problem. But, it's actually a trade-off. So what happens is vaccines are wasted, not just a closed vial wastage, which basically happens due to if the cold chain is not maintained. also due to open vial wastage, which basically is, you have a 10 or a 5-dose vial, and in a 5-dose vial, you open that up, only 3 infants or 3 children turn up for immunization for that particular vaccine. So you open the vial, it had 5 doses, but you could only immunize 3. So effectively, you actually wasted 40% of the vial because, and because the government of India and other countries across the world have that even if a single child turns up, you will still open the vial. So it's not like, just because there's less children, the vial will not be opened due to fear of wastage. So clearly there's a trade-off, and if you have a single dose vials, it's much more expensive as compared to a 10-dose vials. In terms of your other point you mentioned where cold chain is not accessible, and obviously there could be 2 primary reasons where cold chain may not be available. One obviously is there is no cold chain hasn't been procured because of lack of capital expense, or it just hasn't been procured. Or B, there is cold chain, but there is no electricity or sustained electricity for much longer duration to maintain the cold chain. In those certain scenarios, there is already some movement happening where there are various stakeholders who are now developing a solar direct drive fridges or refrigerators, which basically can stay up to 24-36 hours without power. So that's the other intervention. The other is the cold chain bit, where again, Gavi is working and developed a cold chain equipment optimization platform where they're working with countries to prioritize their cold chain procurement, because they clearly believe, for sustaining and rolling out the large immunizations programs, you do need to invest in cold chain equipment as well. But it still is a problem. Thanks.
A question from Shivani again. Why are vaccines so expensive even though it's proven that they are more effective than drugs? Why do we have to wait years to hear about new breakthroughs or new vaccines?
Yeah, so actually the vaccines in public health markets are still very, very cheap, or relatively cheap as compared to what you may hear in the private markets. The rationale or the reason where there's a delay for new vaccines to be developed is because it's just inherently long process. A vaccine development starts from when a cell line or a candidate is created or generated for a certain disease and is able to show in preclinical models that it can provide efficacy or immunogenicity against certain type of antigens. Post that, you will go do some animal studies and then go through phase 1, phase 2, and phase 3. Phase 1 is much shorter, whereas phase 2 and phase 3 are much, much longer. Phase 3 being the longest of all and has a much larger number of clinical trial volunteers as part of that clinical trials to ensure you are able to test it against large number of patient population and measure the right endpoints. So hence, I believe 5 to 6 years is the bare minimum for the time it has taken in the past to develop vaccines. In some cases, much longer than that, and that's the reason why we don't really hear about new vaccines coming online every year or every 6 months. Yeah. Thanks.
So taking our last question, the question is from Samar. What is your sense of current production capacity of Indian PSU manufacturers vis-a-vis the immunization volume needs of the country?
So manufacturing capacities are actually very sensitive or confidential information, which suppliers are not, open to sharing, and to be honest, should not be discussed in public forum because they're very sensitive in terms of how the supplier can, and would how the competitive dynamics will come into play and what price and market shaping scenarios will work on. In terms of PSUs, I think the PSUs we are looking at is we inherently, apart from most of the PSUs have vaccines which were earlier being used, and some of them are developing new vaccines, but at this point in time, most of the new vaccines being used by the government are being procured from private sector manufacturers. So, at this stage, we can only share that most of the new vaccines which the government and the global stakeholders procure are being supplied by private, both domestic and global manufacturers.